have Dr. Miriam Ting. Dr. Miriam Ting graduated with a DMD from Temple University, Philadelphia, and a BDS from the Faculty of Dentistry, National University of Singapore. She completed a certificate in advanced periodontology and an MS of craniofacial biology at the University of Southern California. She's a diplomate of the American Board of Periodontology and a diplomate of the International Congress of Oral Implantologists. Dr. Ting is the founder and director of the Think Dental Learning Institute. She has a private practice, Think Oral Implants and Periodontitis Limited to Periodontology in Paoli. And she's on a faculty of the dental residency program at the Einstein Medical Center. Dr. Ting has had faculty appointment at the University of Southern California, Nova, Southwestern University, University of Pittsburgh, and Temple University. Dr. Ting was recognized as the outstanding periodontal graduate by the California Society of Periodontitis, and other awards included Asia Pacific Dental Students Association Project Competition, first place, Young Researcher Award, first place, ICOI Summer Implant Poster Competition 2015, third place, and ICOI Summer Implant Poster Competition 2016, second place. Dr. Ting has published numerous research and review papers, systemic reviews, textbook chapters on periodontal microbiology and dental implant rehabilitation in peer-reviewed journals such as Periodontology 2000, Journal of Oral Implantology, Implant Dentistry, um, Compendium Journal of Periodontal Research, and European Journal of Oral Sciences. Dr. Ting's publications has over 800 citations in various peer-reviewed journals worldwide. Dr. Miriam Ting, we're very happy to have you today, and we're very excited about what's we're gonna learn today. So welcome, and we're very excited to be with you.
Thank you, Dr. Joseph. I want to give a, I'm really honored to be here today to be able to share this topic with everybody. And I want to give a shout out to Dr. Kiana Shah for putting this whole thing together, like this whole opportunity for so many amazing speakers to get together to share with the world. So without further ado, let's get started with this topic. Just want to apologize that the camera's not working. If not, then I would have loved to be there in visually with you guys as well. So anyway, a little bit about this topic, herpes viral co-infections in aggressive periodontitis and the associated systemic effects. When I first did this topic, it was actually a 2 hour long lecture, but I would like to go over this uh, like I like to summarize this for everyone so that you can get a gist of what this topic is about. So we may not go in detail because if we did, it would actually take more than the 1 hour allotted time we have today. Okay, so for aggressive periodontitis, there are some factors that's associated with it. And let's take a look at what those are. There's inflammation, herpes viruses, and pathogenic bacteria. And this presentation is actually going to cover the evidence behind how these factors have been found to be associated with aggressive periodontitis. Okay, so to start, this is inflammation, and this is a famous paper by Page and Schroeder. And what I really want to show you here is that take a look at the immune cells. These are the neutrophils. And as disease progresses, okay, you could see that there is a change in the number of immune cells and an increase in immune cells, as well as other types of immune cells being mobilized to the area. And as the disease progresses, you can see that on top of the immune cells being attracted to that area, there are all these cytokines being released. So at a certain point, this is not a good thing because all this creates a destructive process in which soft tissue attachment is being destroyed, and so as well as bone is being destroyed. So inflammation is good because it helps us fight disease, but uncontrolled inflammation, like as in when inflammation gets out of hand, it causes more destruction than it does helping the situation. Okay, so the other part that the other factor that we want to look at is the involvement of pathogenic bacteria in aggressive periodontitis. Right, this is the subgingival, um, the bacteria found in the subgingival, what do you call it, the periodontal pocket. Okay, so what this group found, Sokransky, it's also a pretty famous paper in which they look at the groups of bacteria in the periodontal pocket. And what they found was that these groups of bacteria exist in clusters, like they like to survive together in communities. And what they found was that this particular group, the red complex. So they give them colors so that it help us classify them, like the red complex, the green complex, the orange complex. So the different groups of bacteria, some are more virulent than others. So this particular group, the red complex, consisting of monash gingivalis, Treponema denticola, Tannerella forsythis. Okay, they're the most pathogenic group, the most pathogenic complex associated with periodontal disease. Okay, within this group, I want to draw your attention to monash gingivalis, which is a very aggressive bacteria and is associated with a lot of the aggressive periodontal disease. Associated with aggressive periodontal disease, okay, in adults. And then I want you to draw the attention to the green complex here, in particular, Atenobacillus actinomycetum comitans, which is a very aggressive bacteria that has been associated with aggressive periodontal disease in in children and young adults. Okay, so let's move along here to pathogenic bacteria associated with aggressive periodontitis. So we want to make a distinction between aggressive periodontal disease and chronic periodontal disease. For chronic periodontal disease is what you get. It develops over time, mostly in older people. They and the loss of bone tissue, loss of attachment is slow, and it could progress for many years without anybody noticing it. Whereas with the aggressive periodontitis, it's a lot of bone loss in a short amount of time, and the progression is very fast. The bone loss is very severe, and that's so it has a separate clinical presentation compared to the slower progressing chronic periodontitis. So for this particular group of periodontitis, which I'm going to just call them aggressive periodontitis, there are they are associated with these two aggressive bacteria, Atenobacillus actinomycetum comitans. Sometimes I'm going to refer to it as AA, and Porphyromonas gingivalis, PG. Uh, in general, you notice that these two bacteria, AA is more often found in younger adults, PG more often found in older people. Although I do have to say that AA and PG has also been found in healthy people as well. So are they can be found in healthy people as well, but they are more found in aggressive periodontitis patients compared to healthy patients. One thing to note about these bacteria is that they are pretty virulent, and and that they are exogenous bacteria, which means that they can be completely removed from the mouth with proper therapy, meaning that they're not naturally occurring bacteria. Okay, so that's one thing to note, because if you have this bacteria, you can actually totally eliminate it from your oral cavity. Okay, so let's just take a look at how the AA bacteria look under the microscope. Okay, they have two strains, the leukotoxic strains, which has these little rough attachment to the outside of it, and there's the non-leukotoxic strain, which is kind of smooth. Okay, so Obviously, the leukotoxic strain is more virulent than the non-leukotoxic strain. Okay, in culture, the AA bacteria is quite distinctive. It has that star shape presentation in culture, so they're actually very pretty to look at. Okay, and for Porphyra monash gingivalis, under the electron microscope, that's how they look like. In culture, this is how they present. Okay, this it's yellowish, smooth culture, and then as you can see, that's how that looks like when you do a smear, and that's how they grow on a plate. Okay, so let's go on to look at the human herpes viruses. Uh, the, they have been associated with aggressive periodontitis, uh, uh, and I'm going to go ahead and show you how what the studies are that would show that. But before we go there, we do want to take a look at how prevalent herpes virus are in the world, and we can see that the human cytomegalovirus is about is in about 60 to 90% of adults in the United States. Epstein-Barr virus is approximately 90% of the population worldwide. So we do know that herpes viruses are actually very prevalent. So a lot of people may actually already carry this virus without any symptom, without knowing it. Okay, so what are these herpes viruses? So there are three groups, the alpha, the beta, and the gamma. Okay, so in these groups, uh, these are outlined, but what I really want to talk about is the ones that have been associated with periodontal disease. So let's remove the rest. Okay, so let's take a look. Herpes virus simplex 1, simplex 2, cytomegalovirus, and Epstein-Barr virus 1 and 2 has been found in periodontal pockets. And these herpes virus can actually infect periodontal cells. And human cytomegalovirus, these cells are susceptible to it. For Epstein-Barr virus, these cells are susceptible to it. Okay, human cytomegalovirus and Epstein-Barr virus are more commonly associated with periodontal disease than herpes simplex 1 and 2. Although herpes simplex 1 and 2 has also been found in periodontal pockets, but these two, HCMV and EBV, are more commonly found. Okay, so herpes viruses, they do cause a lifelong latency in the sensory ganglion or the inflammatory cells. So that's where they hide uh, in in the body. Okay, so uh, when when we experience immune suppression from disease, from medication, from stress, from advanced age, uh, that could trigger an asymptomatic herpes virus reactivation. Okay, so let's look at the evidence of herpes viruses being detected in the periodontal pockets. Okay, so this is the one of the earliest reports. Berdilla and Serb in 1990 reported that they saw viral inclusions in connective tissue cells from LJP patients, okay, which is localized juvenile periodontitis. So I might refer to that as LJP. And then in 1996, Parr and Slotz, they used PCR, polymerase chain reaction, which is a way of detecting for the genetic sequence of certain viruses. So they used this to try and see if there were viruses, human viruses in periodontal pockets. And they found that, yes, they found viruses in the uh, pockets of patients with periodontitis. Okay, and then going forward, there were other researchers that jumped on the bandwagon, and they also looked at these herpes viruses in the periodontal pockets. And what Kama et al. Found was that human cytomegalovirus was found in higher frequency in progressing periodontitis compared to the sites that weren't progressing. And similarly, Kuba et al. Found that uh, there was increased HCMV and increased EBV in gingival tissue of aggressive periodontitis lesions compared to chronic periodontitis lesions. So here we're drawing a distinction between aggressive periodontitis and chronic periodontitis. So in aggressive periodontitis, the herpes virus is found more often. Okay, so there are other studies done in that respect, and they also go on to look at bleeding on probing. So there is more bleeding on probing if there is a herpes virus infection. That if there is herpes virus infection, there was deeper probing depths, there is more attachment loss, and in general, they found that herpes virus infection and herpes virus co-infection, which means that having an infection of more than one virus, more than one herpes virus in the pocket is associated with periodontal tissue inflammation and destruction. Okay, so that being said, yes, we found the viruses in the pocket, but then we ask ourselves, how do we know if the virus in the pocket is doing harm or is just hanging out? Okay, so that brings us to the point of looking at active virus. So how do we know that it's doing harm? So the virus got to be actively replicating, it's got to be active to be causing harm. So some researchers, Contreras and Slots, decided to look into that. They decided to see if the virus in the disease sites, the sites that are progressing, the sites that is losing attachment, whether the virus, the herpes virus in those sites are active. Okay, so in 1998, they looked at active cytomegalovirus in human periodontitis. Okay, so they did find that there were active human cytomegalovirus in periodontitis patients. However, because we want to see if there is a difference between viral activity in healthy sites compared to disease sites, so that comes to this landmark paper. I believe this is the first paper out there that looked at viral activation in disease sites compared to healthy sites as in the localized juvenile periodontitis patients. So this is a landmark article, and I was privileged enough to work with Dr. Adolfo Contreras and Dr. Jorgen Slotz in, in doing research in this area. Okay, so just want to go over this paper quickly. Just in, uh, in summary, basically there is more virus present in disease sites, meaning the LJP sites, which is first molars or central incisors, because localized juvenile periodontitis has a very distinct clinical presentation. Okay, so we looked at the disease sites and the healthy sites. We found that there were more virus in the disease sites compared to the healthy sites. But not only that, we looked at the viral activation in the disease sites compared to the healthy sites. In this case, we focused in on human cytomegalovirus, mRNA. The reason was because we had the technology to look at that. Okay, so but that is not to say that Epstein-Barr and herpes simplex virus are not active or in that area. Okay, that we do not know. So from this paper, we cannot make that conclusion. But from this paper, we can make the conclusion that in the disease sites, out of the 8 patients that had herpes, cytomegalovirus in the disease sites, 6 of those lesions had active human cytomegalovirus. Okay, and then in the healthy sites of these 8 patients, there was no activity, and even the 2 sites that detected the human cytomegalovirus as present, they were not active. They were not actively dividing. Okay, so that is an important finding. And then the other thing we did was that, with localized juvenile periodontitis, they are often reported with like an age of onset between 12 and 14 years old as to when they say that the disease appears, it's actively breaking down. And then there is also a burnout for localized juvenile periodontitis, where after a certain age, the disease seems to have lost its steam, like the breakdown seems to have the the severity and the speed of destruction seems to have slowed down. So that is like something that um, researchers that have been following localized juvenile periodontitis have observed. So, so because of that, we just took the patients that we had and we arranged them in chronological order in terms of age. And this is just an interesting finding that we see is that for the patients 10 to 14, all our patients had viral activation. Okay, in the older patient, we only had 3 patients in this age group. But what we found was that in these patients, out of the 3 patients, only one of the patients, the virus was still active. The other 2, the virus was not active. Okay, although I do have to state the number is small to make any definite conclusion, but we're looking at a trend here. So we do need we need to make a call for other researchers to jump on board to look into this and see. To do more research on this so we can have a clearer picture. Okay, and then in addition to that, localized juvenile periodontitis, there has been report that it's running in families, like siblings are affected. So what we did was that one of our patients number 1, had a 7-year-old sibling. So we called the sibling in to be screened for localized juvenile periodontitis. Okay, so this 7-year-old sibling had no clinical evidence of localized juvenile periodontitis. However, we did sample 3 gingivitis sites around first molars, okay, because that's the location of onset for localized juvenile periodontitis. So we decided to, let's just take some samples in the area around the first molars and see if there's virus present. And so in this sibling, okay, so this is one patient. So this is a case report in that sense. Okay, but we did find something interesting. So in this one sibling, we found that uh, human cytomegalovirus was present. Epstein-Barr 1 and Epstein-Barr 2 virus was present. Okay, so this sibling has the virus. Okay, there is no breakdown in these sites, but the viruses are present. Okay, and there are 2 viruses present, meaning that there is a co-infection of more than one virus. Okay, but interestingly enough, the cytomegalovirus that was present was not active. Okay, the mRNA was not present. And interestingly enough, uh, the mRNA besides the mRNA not being present, the AA bacteria that is present, that has been positively associated with LGP patient, was also not present. Okay, so from this one case, it may actually draw attention to the fact that viral activation may be related to uh, overgrowth of virulent bacteria. Okay, so let's keep that in mind, because as we go through this presentation, I'm actually going to show some cases in which there is some kind of an association with more patients, not just with just one case report here. Okay, so the other thing we did that, so how about all these patients that we had with LGP? Uh, shall we take a look at the presence of AA and the viral activation? So we have that data. So we did PCR for AA and we did culture for AA. Although for culture, some of it we were not able to detect, okay, because for when you do a culture, sometimes it's very hard to grow the bacteria even though it's present. Whereas for PCR, if even one bacteria is present, it will detect it. Okay, so what this tells you is that for patients with active, okay, so these are the LJP patients. Okay, in these 8 patients with in these 8 patients with active virus, active human cytomegalovirus. Okay, oh wait, hold on, let me rephrase that. In these 8 patients in which human cytomegalovirus was detected, okay, the ones that had active human cytomegalovirus also had positive PCR for AA. So see that? Okay, and for the 2 patients that had no active mRNA, even though the virus was present in them, had no PCR detection of AA. Okay, so this is a very interesting finding here. Okay, so in conclusion, herpes viruses are frequently detected in LGP lesions. Active human cytomegalovirus is associated with the onset of LGP. Okay, so what we can say from that is that the virus is may be damaging the host defense, and that um, reduction or that reduction in the effectiveness of the host defense may give rise to an overgrowth of periodontal pathogens, and that overgrowth of periodontal pathogens can contribute to the rapid loss of periodontal attachment. Okay, so this study is published in a paper in Journal of Periodontal Research. So I've talked about this in summary, but if you want to know more details about this study, you can request for the article on my ResearchGate profile. Okay, so if you can find me on ResearchGate, request the article. There is no charge to get access to this article. And if you want to know more about how the study is done and what the results are, you can read that up in this paper. Okay, so let's look at, like I said, that there is some kind of host immune defense impairment in these in these LJP patients that might be herpes virus related. So let's look at some of the evidence out there. Okay, so these researchers, Suzuki and Van Dyke, okay, 1984 and 1985. So as early as this time period, these researchers, and they're very famous periodontists at that, they've found that in the polymorphonuclear leukocytes of LJP patients, they noted that there was some kind of chemotactic defects. Okay, so as early as 1984, researchers have already noticed that in these LJP patients, the PMNs, the polymorpholeukocytes, are not working properly. Okay, there's something they're not moving as fast as healthy leukocytes. So as early as that time period, researchers have noticed that. Okay. Okay, so 1984, Schooley et al. Found that Epstein-Barr infection can stimulate B cell activation. Okay, so what that does is that it generates these antibodies that kills the neutrophils. So the Epstein-Barr infection can actually cause some kind of neutropenia. Okay, this neutropenia may be localized, which means that the patient may not be neutropenic as a clinical diagnosis, but the area where the Epstein-Barr infection is occurring, there may be a localized neutropenia. Okay, so that's what I'm referring to here, a localized neutropenia, not a systemic neutropenia. Right, and Ograndi, 1986, found that that some of these virus-carrying lymphocytes and epithelial cells have actually decreased antibacterial ability. Okay, so even as early as this time, so note the timestamp, 1986, 1984, like they've already associated that, if there are like some kind of viral infection of these defense cells, there is some kind of decreased ability of these cells to actually kill bacteria, or even a decrease in the function of these immune defense cells. Okay, so therefore, herpes viruses are associated with diseased periodontal sites compared to gingivitis sites. Herpes virus co-infection of more than one herpes virus is associated with increased periodontal destruction, and herpes virus can be reactivated in periodontal sites. Herpes virus has a synergistic effect with pathogenic bacteria. As we can see in the LJP patients, herpes virus is synergistic with AA. In adult aggressive periodontitis, herpes virus is synergistic with monash gingivalis. Okay. Herpes virus can alter the internal structure of immune defense cells, as I've showed you in some of the studies that have been done in 1986. Okay, and herpes viruses can damage the function of immune defense cells. Okay, in particular, human cytomegalovirus can upregulate matrix metalloproteinases. Okay, and these matrix metalloproteinases is associated with periodontal disease. So how it's associated? Okay, metalloproteinases break down the collagen in the periodontium. Okay, and that leads to attachment loss and other not so good outcomes. Okay, so here is where it gets creepy, right? So systemic diseases associated with periodontitis. Periodontal disease can contribute to systemic effects that extend beyond the local periodontal environment. Okay, so these are some of the systemic diseases associated with periodontitis. Okay, cardiovascular disease, diabetes, ischemic stroke, cancer, gastrointestinal ulcer, Alzheimer's disease, rheumatoid arthritis, chronic respiratory disease. Okay, this list is not exhaustive. There could be others, but this list is based on it's based on the systemic disease that we have the most evidence about. So what I'm going to cover in the next section is evidence of how these factors that I showed you that is involved in periodontal disease are also factors that are involved in some of these systemic disease, and how periodontitis and the systemic disease itself can actually make each other worse. Okay, so let's take a look at the evidence. Okay, so factors, look at these factors associated with aggressive periodontitis, inflammation, pathogenic bacteria, and herpes viruses. So we're going to take a look at how these factors are related to cardiovascular disease. Okay, so inflammation is a risk factor for arthrogenesis. Okay. Okay, and pathogenic bacteria, namely monash gingivalis, there is a strong association with cardiovascular disease, and patients with high antibody level against PG has an increased risk of heart failure. Okay, so these patients with chronic vascular disease that have PG, it could be in the mouth. Okay, PG usually occurs in the mouth. Okay, these patients have an increased risk of heart failure. So patients in this category really should make sure to get rid of PG in their mouth, because PG is an exogenous bacteria and can be completely eliminated from the oral cavity. Okay, so the next part, we're looking at cardiovascular disease risk. Calcified carotid artery aderomas is associated with periodontitis, and patients with both periodontitis and calcified carotid artery aderomas have a higher risk of myocardial infarctions. Okay, so if you can't help yourself and you have a calcified carotid artery, you do want to make sure that you control your periodontitis, because a combination of these two does increase your risk of getting a heart attack. Okay, and then let's look at cytomegalovirus and how that is related to cardiovascular disease. So cytomegalovirus apparently can increase the arterial stiffness of the vessels. Okay, so this just says that this virus can increase the stiffness of the vessels, and this increased stiffness of the vessel is actually used as a marker for cardiovascular mortality, meaning that if you have increased arterial stiffness, which is which is associated with cytomegalovirus, it means that you have an increased chance of dying from a cardiovascular disease. Okay, so how is okay, and then also herpes viruses as a group is associated with atherosclerosis. Okay, so so the virus and cardiovascular disease, there are strong associations in that fact because the virus is associated with arteriosclerosis, which is um, a big part of cardiovascular disease. So if you have cardiovascular disease and diabetes at the same time, okay, that makes it even worse. Okay, cardiovascular disease, um, mortality in diabetic patients is 4 times increased compared to non-diabetic patients. Okay, um, so in general, if you have diabetes and you have cardiovascular disease, um, your and you have periodontitis, you have a 3 times higher chance of mortality compared to patients with cardiovascular disease but no diabetes. Okay, so basically it's not a good thing. Okay, so having shown that cardiovascular disease and having diabetes, uh, it's not a good thing. We just want to also look at how these factors is associated with diabetes. So let's say you're lucky enough not to have cardiovascular disease, but you have diabetes. So how does these factors affect diabetes? Okay, TNF alpha produced by periodontal inflammation. Okay, so when you have gum disease, TNF alpha is produced during the inflammation phase. Okay, and then in diabetic patients, TNF alpha is produced by the adipose tissue. Okay, so to make matters worse, the TNF alpha produced by periodontal inflammation and the TNF alpha produced by the adipose tissue of diabetic patients, they work synergistically together to affect the insulin resistance. So it makes the body more resistant to insulin. So if you have periodontal disease and you have diabetes, it's going to make increase your insulin resistance by much more than if you just had one and not the other. Okay, so this is just a paper to show that how the cytokines make the diabetes worse. I mean, the cytokines released from periodontitis can actually make your diabetes worse, and the pro-inflammatory cytokines produced in diabetes can actually make your periodontal disease worse. Okay, so in this part, I just want to say that if you have diabetes and periodontal disease, you really want to control your periodontal disease and control your diabetes because having both of them, the periodontal disease can make your diabetes much worse, and the diabetes can make the disease progression of your gum disease much worse. Okay, so this is something to take note of for patients with diabetes and periodontal disease. Okay, moving along, these factors associated with aggressive periodontitis is also associated with ischemic stroke. Okay, so it doesn't get better. Okay, patients with periodontitis have a higher risk of ischemic stroke and a lower survival rate, okay, compared to patients without periodontitis. What the research has shown is that cytomegalovirus and herpes simplex was associated with increased stroke risk. Okay. Elevated cytomegalovirus IgM levels in ischemic stroke has an increased risk of death and major disability. Okay, for for these patients. Okay, the HCMV IgM is this part here is a predictive factor for poor prognosis of ischemic stroke. Okay, so what that tells you is that if you have human cytomegalovirus in your body and you have a poorer prognosis in the event of an ischemic stroke. Okay, so these factors in aggressive periodontitis, the inflammation, the herpes virus, and the pathogenic bacteria is also associated with cancer. So let's look at what the studies say. Okay, so in this study, severe periodontitis that in which PG is present, okay, there increased risk factor for gastrointestinal cancer. Okay, and so all these cancers are grouped in gastrointestinal cancer, meaning that basically you are increased risk for any one of these cancer. It could be oral cancer, it could be oropharyngeal cancer, it could be colorectal cancer, it could be pancreatic cancer. Okay, so periodontitis can increase the mortality can increase the chance of dying from gastrointestinal cancer or pancreatic cancer, as shown in this study. Okay, and this study is a meta-analysis. So is a data. It's a statistical analysis performed on a systematic review in which these researchers looked at all the studies that was done on periodontitis and cancer. Okay, in this study, they found that EBV-infected epithelial cells contribute to gastrointestinal cancer, and there's so these EBV-associated gastric cancer largest mortality reported in 1990 to 2010. Okay, a lot of people with this gastric cancer, they did not survive. Okay, so going on, these factors associated with aggressive periodontitis is also associated with gastrointestinal ulcers. Okay, so here, periodontal disease is associated with an increased risk of gastric and duodenal ulcers. So these guys, there's actually two studies here have found that. Okay, so herpes viruses, the Epstein-Barr virus reactivation increases the risk to develop pre-malignant and malignant gastric lesions. Okay, gastric ulcers being among them. Okay, so let's look at Alzheimer's disease. Okay, so we heard way back when there was a big, I think a study published in which they found monash gingivalis in the brains of Alzheimer's patients. Okay, PG produces toxic proteases called the gingipanes, and these were also identified in the brain of Alzheimer's patients. Okay, so I just want to make a note here that PG has no business being in the brain. So if the source of PG is probably from the oral cavity. So if you have PG in the oral cavity, you do really want to get rid of it, because there's no reason why the PG should end up in the brain. Whether it's doing any harm or not, there is no reason we should have PG in the brain. Okay, so going forward, for Alzheimer's patients, they did find cytomegalovirus facilitates the development of herpes virus 1 associated Alzheimer's disease. Okay, so herpes simplex 1 has some association with Alzheimer's disease, and if you have human cytomegalovirus, it can actually make it worse. Okay, so these two viruses, they can interact, and the interaction is associated significantly with Alzheimer's disease development. Okay, so how about rheumatoid arthritis? Okay, so we know inflammation is involved with rheumatoid arthritis, but how about the viruses and the bacteria? So let's look at that. Okay, so periodontitis is more common in rheumatoid arthritis. Okay, so Um, so the cytokines released in periodontitis actually can cause, which causes alveolar bone, can also cause like inflammation in the joint, and it can also cause joint destruction. In patients with rheumatoid arthritis, they have an impaired control of Epstein-Barr infection. Okay, so then they have these high titers of antibodies against Epstein-Barr. Okay, so what this is saying, this paper is saying that these rheumatoid arthritis patients that have um, more Epstein-Barr infected B cells than normal controls, they have a tenfold increase in this viral load. Okay, so which mean that uh, it may actually compromise it could make their rheumatoid arthritis worse. Okay, so I believe this is the last group of systemic disease that I'm going to cover. Okay, before we go on to how do we manage these conditions. So the next part is the most important part of this whole lecture. So if you could bear with me, we're going to see how these factors are associated with respiratory disease. So periodontitis is strongly associated with chronic obstructive pulmonary disease. Okay, that is in this paper. Okay, chronic periodontitis is significantly associated with reduced respiratory function. Okay, so over here. So if you have chronic periodontal disease, your respiratory function is diminished. Okay, so having said that, um, we want to actually I just want to talk a little bit about like how the neutrophils contribute to the inflammation, which actually makes chronic obstructive lung disease worse. So this inflammation actually leads to injury of the lung tissue. Okay, so this part talks about the disease and inflammation. So so there are some similarities in the disease mechanism between respiratory disease and periodontitis. Okay, because so some of the similarities is that in these two diseases, we have reports of dysfunctional neutrophil behavior, which we see in periodontal disease and we see in respiratory disease. Okay, and this sustained neutrophilic inflammation can lead to connective tissue loss. So the question is, can treatment of one influence the severity and progression of the others? Meaning, if we treat our periodontal disease, we get the inflammation under control, can we limit the progression of our respiratory disease, right? On one hand. On the other hand, if we treat our respiratory disease and keep that under control, can we reduce the severity of our periodontal disease? So that is the question. Okay, so let's look at the pathogenic bacteria. Are these pathogenic bacteria associated with these respiratory diseases? Okay, so there is an increase in Porphyromonas gingivalis in patients with chronic obstructive pulmonary disease, okay, compared to patients with no respiratory disease. Okay, and what these guys found was that these researchers found was that increased Porphyromonas gingivalis significantly reduced the respiratory function of the patients with chronic obstructive pulmonary disease. So if you have this disease, COPD, having a PG would actually reduce the ability of your lung to function. Okay, so thus PG being an oral source coming from the oral cavity, the presence of PG in the oral cavity can weaken your lung function. Okay, so that is another reason why if PG is present in the oral cavity, we should make every effort to eradicate that completely from the oral cavity of patients with periodontitis. Okay, so how are these respiratory diseases related to the herpes viruses? Okay, so in this study, Epstein-Barr EBV DNA was significantly detected in serum samples of ICU patients with respiratory failure. Okay, um, so if you have Epstein-Barr virus uh, and you are in the ICU, your chances of dying is increased. Okay, so that's what this paper found. Okay, so it's how is the virus related to respiratory diseases? Okay, inflammation in COPD patient, okay, which can be triggered by tobacco, air pollution, and in our present state, it could be triggered by the COVID-19. Okay, it may promote cytomegalovirus reactivation. Okay, and also smoking can do that. Okay, so if they have a longer smoking history, there could be a higher level of CMV reactive antibodies. Okay, so the reactivation of cytomegalovirus may in turn trigger systemic inflammation characteristic of COPD patients. Okay, so that is not a good thing. Okay, so having gone through the systemic diseases associated with periodontal disease, I want to move on to if we can control the associated factors, can we control um, the periodontal disease and limit the systemic effects? Okay, so if we can control the associated factors, we can control the periodontal disease and we can limit the systemic effects. Okay, so let's look at these factors. Okay, so let's look at how we can control. I just want to say there's so many pieces to a puzzle, so can we make sense of it? So the preceding part of this lecture, we're going to try and make sense of this. So how do we control the factors associated with periodontal disease? Okay, so look at these factors. If you have uh, one of these factors, your immune system might be strong enough to prevent periodontal disease. But if you have all three of these factors together at the same time, this may overcome your body's ability to fight aggressive periodontal disease. So, how are we going to control that? So I'm going to give some strategies for, in general, of how we can control these different uh, um, factors involved in associated with aggressive periodontal disease. Okay, so first, how do we control inflammation? Okay, we can control inflammation by improving the oral hygiene. Okay, examples of that is brushing, flossing, using the proxy brush, or even using the water pick. Okay, so how do we control bacterial infection? Okay, we can control bacterial infection by with use of antimicrobials. Okay, we can use, okay, basically, when I say control of bacterial infection, I don't mean control of bacteria that is involved in chronic periodontal disease, okay? Because bacteria involved in chronic periodontal disease includes bacteria that are indigenous in the mouth, meaning that these bacteria are naturally occurring in the mouth, but too much of this bacteria contributes to chronic periodontal disease. However, in the aggressive periodontal disease, the bacteria involved are not bacteria that are normally present in the mouth. Okay, so the use of antimicrobials are not recommended for chronic periodontal disease because there is no way you can get rid of bacteria that is normally existing in the mouth. Okay, so you do have to know that the use of antimicrobials, um, if you want to use it, you want to know why you're using it, how you're using it, and how to use it, like in what combination. So when we use antimicrobials, our purpose to use that is to target these pathogenic bacteria, um, meaning the AA and the PG. Okay, so uh, our focus for using antimicrobial is very specific. It targets specific bacteria. So we do want to take note of that when we implement antimicrobial therapy. Okay, so some examples of antimicrobials we could use: amoxicillin and metronidazole, ciprofloxacillin and metronidazole, tetracycline, amoxicillin, and metronidazole. Okay, so what I want to say is that all these combinations have um, have been documented to work. Okay, this is an article. This is a review article I did with Dr. Jürgen Slotz. Okay, and in this article we looked at all the different antibiotic combinations being used in patients in which research was done, at what concentration, at how what the antimicrobial protocol is, and what the outcomes were for treating different kinds of periodontal disease. So from this, if you want to know more details about it, you can request for the article on my ResearchGate profile. It's free to request that article from me if you don't have library access. So if you want to know how antibiotics are being used and which protocol is most efficient, because I do want to say that they all work to a certain extent. Um, how well they work, I can leave that up to you to decide by looking at the studies, and this is outlined in the tables in this paper. Okay, so some combinations may work better than others, and how I choose my antibiotic protocol is based on the results, the outcomes of research studies that have been done and what they report. And from there, I deduce for myself what the most effective antibiotic protocol is. Okay, so this paper has actually 202 citations. Okay, and then because, like I mentioned, the use of antibiotic is target at specific bacteria. So and those two bacteria mainly is AA and PG, and AA and PG has been implemented and strongly associated with aggressive periodontal disease. And in this paper, which I did with Dr. Slotz, it's a review paper. It outlines the prevalence of AA and PG. So you can find out in this paper, like in healthy people, in chronic periodontitis, in aggressive periodontitis, what is the occurrence of these bacteria and how prevalent they are in different periodontal conditions and how to treat them. Okay, so this study will actually talk about the most effective antibiotic recommendations to target these bacteria and remove it. Okay, so to give you a sneak peek into that, I do prefer, okay, to use amoxicillin and metronidazole combination. The reason for that is that this combination will kill the pathogenic bacteria, but at the same time, it will spare the good bacteria that is present in our mouth. So what it does is that it removes the bad bacteria and it gives the good bacteria a chance to overgrow and take over the niche that is previously occupied by the bad bacteria. Because to understand antimicrobial therapy, you have to understand that it's one thing to get rid of the bacteria, but once you remove the bacteria, you create a void. And to be effective in your antimicrobial therapy, you have to fill that void. Okay, if you don't fill that void with good bacteria, what if another bacteria, like a more virulent bacteria, something that is even worse than what you're targeting, takes over that niche? Okay, so if that if the like the bad bacteria takes over that niche, then you're going to have an even worse situation. So that's where that occur, where you notice that, like sometimes people take antibiotics and they develop like an unwanted super infection with some other bacteria. So that is the reason. So because of that, when you implement antimicrobial therapy, you want to know what you're doing with the bacterial flora. So when you remove the bad bacteria, at the same time, you want to fill that void with a bacteria that is not virulent, that is going to live in harmony with the ecosystem of the mouth. Okay, so what this antibiotic combination does is that it enables these bacteria like the actinomyces, some of the streptococcus, not the karyogenic type, the non-karyogenic type, to overgrow and take over that niche, creating a healthy oral environment. Okay, so if you want to read more about that, because of the limit of the time, um, you could request for this article on my ResearchGate profile. It's free to request for the article if you don't have library access. So this article is actually very well cited. A lot of people actually go to this article to figure out um, how to manage these specific bacterial specific aggressive periodontal disease. Okay, so another way you can control oral bacteria is to the use of oral rinses. Okay, these are some examples: sodium hypochlorite, chlorhexidine, iodine-based mouthwash rinses, acetylpyridinum chloride, and chlorine dioxide. Okay, I just want to make a note that when you choose an oral rinse, okay, you want to choose if your objective is to kill bacteria, okay, and not as a breath freshener, okay. If your objective is to kill bacteria, you do want to make sure that the mouthwash is at a minimum concentration, minimum bactericidal concentration to kill the bacteria. So if you choose a mouth rinse because you want to kill bacteria, you got to make sure that the chemical in the mouth rinse is actually concentrate at the correct concentration that is bactericidal. Okay, otherwise it could serve other uses, as a breath freshener and stuff like that. That is okay, but if your objective is to kill bacteria, you got to make sure that the mouth rinse is at a concentration that it's able to kill the bacteria that you have in mind to target. Okay, and in this case, the use of our oral mouth rinse is not to kill AMPG. It's long-term use of oral mouth rinse is to reduce, is to help the patient control the overgrowth of indigenous bacteria. Okay, so this, just so we can go over so we understand why we're using the mouthwashes. Okay, um, the overgrowth of indigenous bacteria, although they are good, less harmful bacteria, they can still cause inflammation. And we know from this that inflammation is bad. Okay, so the use of the mouthwash is actually trying to just control the overgrowth of these indigenous bacteria. Okay, so that it's just to help the patient. So if the patient is having some difficulty with brushing, or maybe they didn't brush as well, they missed some spot. So what these mouthwashes do, if you select the one that is bactericidal, these mouthwashes will kill the bacteria. Okay, but it's very important to know that the mouthwash does not take over brushing the teeth, because even though it kills the bacteria, the dead bacteria is still there. Okay, so over time, if the patient is not brushing the teeth, the dead bacteria is just going to accumulate, and there's just going to be a lot of dead bacteria. All right, so you still have to emphasize to the patient that brushing their teeth is important. Their 3 monthly visit to the dentist is important, because if they are missing it, and if they're missing these spots that the mouth rinses are getting to, but there's clumps of dead bacteria. So if um, if they are not getting these spots, then then they have to. So when they see their dentist every 3 monthly, the dentist can help them remove those clumps of dead bacteria. So that's why it's so important that they keep their 3 monthly visits. So that's part of the rationale for using the oral mouth rinse. So it's just something to help the patient. It doesn't stop the gum disease. It doesn't cure the gum disease. It doesn't prevent the gum disease. It's just one extra step in the whole protocol of periodontal maintenance. Okay, so let's go on to how do we control the herpes virus infection. Okay, so there are a few ways to control the herpes virus infection. You could use systemic antiviral therapy, initial periodontal therapy, believe it or not, has some effects. Surgical and antimicrobial therapy also has some effects. So how effective is it? Okay, let's look at some of the studies. The next few slides, I'm just gonna go over. I just want to say that a lot of the stuff I presented is not just my opinion. It's just that I'm just drawing attention to all the researchers out there that have put in a lot of effort to do the research. I'm just drawing attention to their research to let everybody know that how these conditions can be treated. Okay, so antiviral therapy is usually carried out first because the bacterial overgrowth is usually triggered by the herpes viruses. Okay, so if you want to implement systemic antiviral therapy, you want to use uh, valacyclovir 500 milligrams twice a day for 10 days. Okay, so this is the recommendation published in Slots 2020. There are, however, some side effects, okay, nausea, stomach pain, headaches, and dizziness. So you do want to warn your patients about that. There are some limitations to the use of antiviral. Okay, the limitation is that it only works if the virus is active. Okay, so if so you have to implement antiviral therapy at the point in time that the virus is active. Okay, sometimes it's really hard to know when the virus is active. Okay, so this strategy is very often prescribed blind because unless you have facilities to test for the mRNA of the herpes virus, there is no way you can tell that the virus is active. So that is one of the limitations of systemic antiviral therapy. Okay, so it only works if the virus is active. If the virus is active, the antiviral will stop it in its track. Okay, so valacyclovir is very expensive, so it can be substituted for acyclovir. Okay, so this is a case report. Okay, Sunday et al. 2008, they did a case report. They consulted with the clinical virologist. Okay, so they gave the patient Valtrex, and what this did was that it decreased the viral load to below detection limit. The clinical condition was improved, the pocket probing depths were reduced, and there was no more bleeding on probing. And this condition, this clinical improvement was stable even a year after the therapy. Okay, so let's look at how initial periodontal therapy can control herpes viruses. Okay, so these two studies, okay, they looked at initial periodontal therapy. They found that initial periodontal therapy can eliminate or decrease the herpes viruses. Okay, right, and then this is another study in which they found that initial periodontal therapy can decrease the DNA of human cytomegalovirus and Epstein-Barr virus in the subgingival sites as well as in the saliva. Okay, and by doing that, when you decrease the herpes virus in the saliva, you can um, you can actually diminish the herpes virus transmission from person to person. So surgical and antimicrobial therapy can also have an effect on the herpes viruses. So this study, they found that it statistically significantly decreased the herpes virus um, after therapy. And in some cases, it completely removes it, as in human cytomegalovirus, and it reduces it in Epstein-Barr virus. Okay, so there are other strategies in which you could control all three factors. And with the use of lasers in periodontal treatment, the lasers can kill the bacteria. It can also kill the viruses. The lasers can reduce inflammation. And yeah, I was going to say, the lasers can denature the viruses. So with the lasers, you can actually combat all three factors at the same time. Okay, having said how the periodontal therapy affects the viruses, how it affects inflammation, how it affects the bacteria, so uh, I just want to go over a little bit about how the periodontal therapy um, affects the systemic health. Like, if you have periodontal disease, you get that treated. How does that affect your systemic health? Okay, so in patients with diabetes, if you have good if your periodontal therapy was successful, it will decrease the systemic TNF alpha. It will improve the metabolic control, reduce the insulin resistance, and reduce the HbA1c. Okay, so lots of benefits to get the periodontal disease under treatment for patients with diabetes. How about patients with cardiovascular disease? Okay, for patients with cardiovascular disease, non-surgical periodontal therapy will reduce the inflammation. By reducing the inflammation, you reduce the inflammatory markers, and you can decrease your vascular risk, and you can decrease your the severity of your cardiovascular disease. Okay, so over here, these guys look at periodontal disease treatment, and what they found was that periodontal disease treatment can improve cardiovascular outcomes. Okay, and what that means is that it can reduce the chances of dying from cardiovascular disease. Okay, so how does periodontal treatment affect ischemic stroke? Well, preventive dental treatment for periodontal disease can reduce your risk of ischemic stroke. Okay, thank you very much. That's all I have for today. How are we doing here? Hello, are we still online? Hello?
Hello?
Hello? Yes.
Dr. Ting, very,
Yes.
very, very thorough presentation and a beautiful summary and a very good grip for all the literature. Beautiful.
Thank you
Um,
so much.
thank you. It's wonderful and it's overwhelming amount of information, but it cannot be a better grip than that in all the literature. I'm waiting for anyone that have any questions that I'll start showing. So I'm asking if anyone have any questions that are watching, let us know. Um, and uh, it's very interesting to see the kind of treatment that you were mentioning as well with the lasers and amoxicillin with metronidazole. I have a question for you. If you used instead of amoxicillin augmentin with the clavulanate, would that be recommended as well? Or you prefer amoxicillin with metronidazole will be more than enough?
It Okay. Let's look at what clavulanic acid does. Okay, it actually there is no harm in using it. It does increase the cost of the medication, and at the same time, we're using amoxicillin and metronidazole combination because we want to encourage the good bacteria from overgrowing. Okay, and the clavulanic acid actually is targeting the good bacteria. So there is no added advantage to use it, but
Okay.
if you want to use it, it may not, I mean, it's still effective, but not as effective as if you didn't use it.
So amoxicillin. Um, with the GI cancer and the chances for increasing, this is uh, you highlighted that very well, and I think there's a much recent more like awareness of that recently than before,
Mm-hmm.
and
Yes.
uh, GI cancer with last decade, I think the increase is higher, and literature and research to for it have been much more extensive than before, and you highlighted that very well as well.
Thank
I'm just waiting if
you.
anyone
Well,
have any questions.
it I would say that the herpes virus's involvement in periodontal disease is not emphasized as much because I think right now in the periodontal arena, the dental implants is like big thing. So a lot of times the periodontal disease itself has been like sidelined by the developments in dental implantology. So I think with this, I mean, with this platform is like um, publicized all over the world. And I think it's a good way to um, get the message out that hey, you know, periodontal disease has big systemic effects, and we actually do need to take care of our gums uh, at the same time as taking care of our health. So, you know, I really appreciate this opportunity to be able to get the word out.
Beautiful, very thorough grip on all the literature. Thank you very much. Beautiful presentation. Uh,
Okay.
Thank you, Dr. Ting. I'm just waiting if anyone have any questions. I think they'll start uh, like posting more of the videos online and sharing it, and then there'll be more questions later on. But
That'll be fine.
for this one now for the live, thank you very much. We love to have you, and it was it was a very thorough, beautiful grip on all the literature. Thank you, Dr.
Thank you.
Ting. Hopefully, we'll see you soon.
Thank you, Dr. Joseph. Thank
Thank
you for
you.
this opportunity. And thank you, everyone, for tuning in. It's my pleasure to be able to share this topic with all of you. Okay,
Thank
have a
you.
great day. And thank you so much, everyone.
Thank
See
you.
you guys
Thank you.
soon.
Beautiful presentation. Thank you. Bye bye.
All right. Bye bye.